respected chairpersons and learned audience. I'll be speaking on what's new in pediatric ophthalmologist. My colleague Dr. Prachi Agashe has helped me with this PPT. Well, we all know a child's eye is not a miniature adult's eye. It is different in many, many ways. And so the management of the child is now a subspecialty in itself. So this is the newer advances that we will be looking at. In many ways, refraction still remains the same. Cycloplegic refraction still remains the cornerstone. And in younger patients, retinoscopy is the only way, even though we have handheld autorefs. And dynamic retinoscopy definitely is underrated and which we should do more and more often. So when peripheral retinoscopes gives you an idea of a globe shape and value, and we can learn so much more from that. So newer additions is peripheral retinoscopy is becoming more and more important. The handheld devices are there, so they are useful when we are doing a large school screening. But then they are just sensitive, they are not that specific, and we need again to do more. In myopia, we know there is a huge change with the ATOM studies and the LAM studies that have happened. And it is the peripheral defocus that is nowadays becoming more and more important. So we now have myopia control glasses of various kinds, the DIMS lenses, the HALT lenses. There is orthokeratology, there are contact lenses which can be worn at night, and then during the daytime, a patient will be free of contact lenses. They also are thought to work by achieving relative peripheral myopia. And amblyopia is something, in spite of all the pedic studies that have happened, that we still have to look for, because earlier we were diagnosing amblyopic eyes later, perhaps in the second decade or by the time the child was 8 to 10 years old and they were in school. Nowadays, we are doing it in preschool children as younger and younger children are getting tested. So we have the traditional occlusion, refraction, atropine, and carbidopa, levodopa. But nowadays there is dichoptics, binocs therapy, perceptual learning, amblyopia glasses. There are so many new things that have come that can be done. In this, the tablets that are there, and we have our own Dr. Pradeep Deshpande from Maharashtra who has been trying to do it, and he's trying to get it, the patent registered, which is based on the similar principle. But dichoptic training is something that is followed more commonly, and my senior and friend over here, Dr. Prasad Varimbe, has a data of more than 300 patients on this dichoptic treatment, which are actually anti-suppression exercises that will translate to increasing visual acuity and stereopsis. So here the contrast for the good eye is reduced, thus aiming at a balance with the amblyopic eye. And the binocular vision is trained by video game tasks that can only be solved binocularly. So we have patients whose perhaps visual acuity may not improve more than 1 or 2 lines with binocs therapy, but their stereopsis definitely improves. And patients say, if they are older patients, even the parents say of younger patients, that the child is able to do a lot of tasks much better than what they were doing earlier. So it is definitely better than patching. And then I'll just go on. I don't have much time. So we have the QRC software. This is the Binox software that you see. Again, for pediatric cataracts, nowadays more and more doctors are putting in lenses in younger and younger children, which also has its own implications in the long term. And now we have to look just beyond the eye. There are genetic and systemic associations that are there. But even then, if we put a lens very, very early, then we have a myopic shift that happens. It's just how big that shift is. And whatever else we do, still multifocals are a big no-no. Torics have not been tried in a very big way because, again, the child's refraction changes. But if there is a large astigmatism, then definitely we should think of them too. The congenital nasolacrimal duct, the principles remain the same. Probing, nowadays intubation has come up, and intubation does help a lot. In retinopathy of prematurity, there has been, of course, a huge change that has happened, and the term aggressor posterior ROP is replaced by aggressive ROP because there is an increased recognition that this may occur beyond the posterior zone. Also, with the IROP classifications, earlier the focus was on doing a lot of treatment, giving anti-VEGFs, giving lasers, but we have to understand that it does not stop there. As a child grows older, the chances of myopia, chances of strabismus, chances of low vision are much, much higher in these children, and they also have to be dealt with, not just the retina itself. And the last I would like to say is in retinoblastomas, the old view was, of course, enucleation, and a lot of us who used to work or study in medical colleges or NGO hospitals, we would see patients at the very end when the retinoblastomas have really, advanced a lot. But now salvaging the globe is a priority, not just salvaging life, and salvaging vision is also a priority. Thank you.